Okay. A very good evening. I welcome you all to the webinar of the Chandigarh Ophthalmological Society, Retina Clinics for Comprehensive Ophthalmologists. We have very eminent faculty with us as part of our program today, and it's my pleasure to briefly introduce all of them. Professor Vishali Gupta heads the uveitis and VR services at the Advanced Eye Center, PGI. She is currently president of the Uveitis Society of India, and in the past has also been the secretary of the Vitreoretinal Society. In addition to the many stellar achievements, which I think are too many to enumerate here, I think the feather in the cap is the collaborative ocular tuberculosis study group, which ma'am is spearheading, and whose publications and recommendations are likely to be part of some of the landmark studies of ophthalmology, I think. We then have Professor M.R. Dogra, who again needs no introduction. Sir was chief of the Advanced Eye Center, PGI, for till a few years ago, and after superannuation is now the director of the Vitreoretinal Services at Grewal Eye Institute, Chandigarh. Sir is one of the architects of the ROP services in India, and all of us who've had the good fortune of working with him know his passion as well as his compassion towards each of his patients. Thank you, sir, for joining us today. We then have Dr. Manisha Agarwal, who's heading the Vitreoretinal Services and Clinical Research at Dr. Shroff's Charity Eye Hospital. She did her VR fellowship from Shankar Nethralaya, Chennai, and is currently the secretary of the Uveitis Society of India and the joint secretary of the Vitreoretinal Society. Dr. Subina Narang looks after the Vitreoretinal Services at the Government Medical College and Hospital, Sector 32, Chandigarh, where she is associate professor. Dr. Ravinder Malhi is in charge of the VR services at Dhami Eye Care Center in Ludhiana, a department she helped build from scratch in 2002 and is heading since then. In fact, when I joined post-graduation in PGI in 1999, Dr. Subina and Dr. Ravinder were my first SRs, and it's a pleasure to have you both here. Dr. Reema Bansal is additional professor at the Advanced Eye Center and also a member of the Scientific Committee of the Uveitis Society of India. She's also gone into the field of clinical research now and recently completed her PhD on vitreous biomarkers in intraocular tuberculosis. And she's also now heading the lab at the Advanced Eye Center. Dr. Deeksha, Dr. Mohit, and Dr. Anirudh are assistant professors at the Advanced Eye Center, PGI. And each of them is well on their way to making a niche in their areas of subspecialty. Dr. Kanika and Dr. Simarajan both did their post-graduation and senior residency from PGI. Dr. Kanika has since moved on into the private sector, while Dr. Simarajan is still with us as a senior research associate in the vitreoretinal and ROP services. I now request ma'am, Dr. Vishali Gupta, to please chair the session and take over for the rest of the webinar. Thank you.
Thank you, Chintan, and thank you, COS, for giving us an opportunity. For the sake of comprehensive ophthalmologists, we have just divided it into different clinical situations that all of us might be encountering in whichever practice setting we are. So the format is we have a speaker who's going to give a very simple way of how do you manage that situation, followed by a discussant. Discussant will be mainly giving a summary of what has been already told and answering the questions that all of you can send on the platform that has been provided to you. Continuing with our first situation is Dr. Subina Narang, who will tell us how do we manage a patient who comes with bilateral combined retinal vascular occlusion. And then Manisha will be giving a commentary on this. Subina?
Thank you, ma'am. I think I would start the... I think my slides are visible now.
Yeah, go to slideshow, please.
Yes, ma'am. At the outset, I would like to thank Dr. Vishali and Dr. Chintan for calling me over for this webinar. I would be sharing very interesting case with you all. She is a 19-year-old Indian female who came with the chief complaint of marked diminution of vision in both her eyes for past 1 day. Patient gave history of some blackouts which were 10 days back and 2 to 3 episodes were there. And now patient presented with sudden pain test marked decrease for the past 1 day. There was some vague history of fever and headache with joint pains, which was 1 month back, and she took self-medication for that, and it got relieved. On examination, she was healthy female. Her temperatures were high, so she was febrile when she walked in, and pallor was present. Otherwise, she was looking normal. The visual acuity was hand motions close to face right eye and counting fingers half meter in the left eye. She had relative afferent pupillary defect in the right eye. Slit lamp biomicroscopy showed cellular reaction in both her eyes. Otherwise, external ocular movements were full and conjunctiva and cornea were normal. Posterior segment examination showed disc edema and dilated tortuous veins was seen and hemorrhages in all 4 quadrants. There was boggy retinal swelling and it was retinal pallor which was there. So if I see the montage of fundus montage, it is clearly showing some soft exudates, dilated tortuous veins, arteries are attenuated and hemorrhages are in all 4 quadrants. However, the area of cilioretinal artery is spared. The picture in the left eye was something similar, but it was limited to the superior part of retina. You can make out very clearly the edema in the superior part, and the inferior part is normal kind of retina, which we can see. Plus, she has perivenular sheathing, which is present, which is seen in the periphery, and hemorrhages are restricted to the upper quadrant, upper half of the fundus. OCT is showing macular edema with serous retinal submacular detachment. Fluorescein angiography showed that there was perfusion of the cilioretinal artery area, and rest of the fundus there was gross ischemia. In fact, the dye arrest was 1.5 disc diameter from the disc. It was hardly any perfusion. Similar were the pictures in the right eye. However, it was limited to the superior part of the retina, and the inferior part of the fundus looked normal. So summarizing, we have 19-year-old female who's coming with a history of pain that's decrease in vision following fever and myalgia. Her fundoscopy is revealing right eye edematous pale retina with cherry red spot and dilated tortuous veins, perivenous sheathing, and hemorrhages in all 4 quadrants. FFA is supporting the diagnosis of ischemia, and left eye is having similar picture, but the things are limited to the superior half of retina. Our provisional diagnosis was combined central retinal vessel occlusion, central retinal vein occlusion, as well as central retinal artery occlusion. However, in the left eye, it was hemispheric combined retinal vessel occlusion. So this was a very unusual case, bilateral loss of vision. We thought of the differential diagnosis. There are few case reports of combined retinal occlusion. We limited our diagnosis to something like she was having inflammatory reaction in combined occlusion. So our possible diagnosis, there were systemic lupus erythematosus, it could be Behçet, syphilis, cat scratch disease. Combined retinal vessel occlusion has been reported in all these diseases with inflammation. However, we could not rule out the other causes: infective endocarditis, leukemia, lymphoma, hyperhomocystinemia, septic cavernous sinus thrombosis, or posterior scleritis. So whenever we see bilaterality about bilateral vein occlusion, we think of diagnosis which is beyond our diabetes and hyperlipidemia. Once we had this provisional diagnosis, we came to again general physical examination. We examined the patient again. Patient had some skin lesions. They were discoid plaques with central depigmentation and adherent scales and surrounding hyperpigmentation. If you see here very carefully, this was present on the nose, on the malar eminences, and this was sparing the nasolabial furrow, which is very classic for discoid lupus erythematosus. Patient also showed photosensitivity of these rashes once the patient was exposed to sunlight. This is the flaring up of these rashes on exposure to sunlight. There were other skin lesions also, which was suggestive of vasculitic lesions. They were on palms, soles, and tongue of the patient. Systemic investigations were done. It showed patient was anemic, hemoglobin was 8.5, ESR was raised, C-reactive proteins were highly raised, anti-nuclear antibody, anti-neutrophil antibody was positive, which clinched the diagnosis. Complement was again decreased. However, notably, anti-phospholipid antibodies in this patient were normal. We were expecting them to be high. Skin biopsy was also done to confirm the diagnosis, and direct immunofluorescence showed immunoglobulin G2 linear positivity at dermoepithelial junction. This was again corroborative with the findings of systemic lupus erythematosus. However, MR angiography of the brain did not reveal anything. Normally, it is seen that 70% of the cases of retinopathy with SLE have CNS involvement. However, this was inconclusive. SLE manifestations in our patients was fever with myalgia and weight loss. Cutaneous manifestations were there. Hematological manifestations were there. And retinal vaso-occlusive disease was there, which is very rare, which is only in 5% of the cases of SLE. The patient fitted into the diagnostic criteria for SLE. According to new criteria, we give score to each of the findings, and our score was more than 10, which confirms the diagnosis of SLE. Emergency treatment was given before all these investigations. Once it was CRAO and CRVO, we definitely gave treatment for CRAO. Paracentesis was done for the patient. However, there was no improvement. These patients are known to have poor prognosis. Patient was started on topical antibiotic and steroids in view of the inflammatory reaction. And in consultation with the internist, the patient was started with oral steroids, systemic immunosuppression, and antiplatelet drugs. In view of the inflammation in this patient, it was the flaring up of SLE which led to this vessel occlusion. Patient was kept on very, very close follow-up. At the earliest diagnosis of neovascularization of the disc, the patient was taken up for aggressive PRP. It has been seen that 54% of the cases where PRP is done have a better prognosis in occlusive SLE retinopathy. And this is 1.5 month follow-up. This is showing resolving intraretinal hemorrhages with cord-like vessels, cord fibrotic vessels, which are present all over the fundus and in the superior half in the left eye. We also gave anti-VEGF because it has been seen that in SLE, anti-VEGF works well. So at 1.5 month follow-up, there's resolution of macular edema and the vision goes to 660 in the right eye and 612 in the left eye. So the take-home message in this unusual case was that once you see a bilateral retinal vessel occlusion, or you see a combined retinal vessel occlusion, our antennas goes up and we go ahead with thorough systemic evaluation of the patient clinically as well as systemic investigations need to be done. And this case highlights that rare occurrence of bilateral combined retinal vessel occlusion as a presenting feature of SLE. This case was diagnosed as SLE from ophthalmology. She was not a diagnosed case of SLE. Thank you.
Thank you, Subina, for a very interesting case. Manisha is the discussant for case. Let's have Manisha's viewpoint on this case.
So, ma'am, if you allow me, I'll just share a few
Of course,
my slides.
of course, go ahead. Yeah.
Is my screen visible?
Yes.
So good evening, everyone, and thank you, Dr. Subina. That was indeed a very interesting case. We often read about SLE, but it's very rare to be seeing such a classical case of SLE in our clinics. Now, one thing which is very important for all of us to know that when we have a patient of combined artery and vein occlusion, it can be a combination of any of the following. So it could be a branch retinal artery occlusion with a vein occlusion, or these various combinations which I have highlighted. You can find any one of these. The causes of unilateral combined occlusion primarily are cardiovascular risk factors, which we often see like hypertension, diabetes, hyperlipidemia, obesity, smoking, and metabolic syndrome. But having said that, even in SLE, very often the usual presentation is a unilateral combined occlusion, and it's very rare to find a bilateral occlusion, as was in the case of Dr. Subina. So these are the various causes of bilateral combined occlusions, which I have highlighted in this slide. And of course, SLE was very much the cause in this particular case, which was presented. But the other things which we have to keep in mind is the Behçet's disease, things like Wegener's, giant cell arteritis, even patients with posterior scleritis and ocular trauma also sometimes can present with a bilateral combined occlusion. The clinical features, of course, as was in this case, you can have a hyperemic and an edematous disc, the tortuosity and dilatation of veins. You can have several retinal hemorrhages spread throughout the fundus with cotton wool spots, and also the variable degree of retinal ischemic whitening can be present. I won't go into the details, but of course, as highlighted, you can have a delayed filling of the retinal vessels with a prolonged retinal arteriovenous circulation time, early retinal CNP areas, and in SLE particular, you find extensive CNP areas leading to early neovascularization. And OCT, as highlighted over here, you can have this hyperreflective band secondary to a arteriolar occlusion. Now, coming to SLE in focus, SLE, as we all know, is a chronic autoimmune disorder which affects multiple organ systems like musculoskeletal system, cardiovascular, the skin, the neurological system, the renal system, and all these have to be very much kept in mind. And severe vaso-occlusive retinopathy is a very rare form of retinopathy seen in the patients of SLE, often associated with extensive capillary non-perfusion areas, leading to an early neovascularization and thereby leading to poor visual prognosis. Now, various systemic manifestations of SLE have been described by the American College of Rheumatology, and these are all the signs that we have to look for when we are suspecting SLE. So in this particular patient, though you had the skin lesions and you had several other telltale signs of SLE, but apparently she had never been diagnosed with SLE in the past till she presented with a vaso-occlusive retinopathy in both the eyes and unfortunately with a drastic loss of vision. In young females, what's important to take is the history of miscarriages, which very often happen secondary to the recurrent thromboembolic events. These are the various lab investigations that we have to do in a patient of SLE because they often have hemolytic anemia with neutropenia and lymphopenia. And these are the specific antibodies that we have to look for, like ANA, like the p-ANCA, the anti-SM antibodies. And what is important are the anti-phospholipid antibodies, both anti-cardiolipin and lupus anticoagulant antibodies, because these are said to be correlating with the occurrence of the vaso-occlusive retinopathy. Surprisingly, in the patient which was presented by Dr. Subina, though the APAs were not elevated, and still the patient had a vaso-occlusive event in the fundus. These are some of the other investigations that we have to do: urine analysis for the impact on the renal, like a renal vasculitis, and also MRI brain, which was rightly done again by Dr. Subina to rule out a CNS vasculitis. When I reviewed the literature, these were several anecdotal reports reporting the cases of SLE who have presented with combined occlusion. The exact pathogenesis of a simultaneous BRAO and CRAO and CRVO in SLE is still unknown, but it is the underlying hypercoagulable state that is considered to be the main underlying cause for a vaso-occlusive event. The acute flare of the disease can be predicted, or it can be precipitated by any event of acute infection, surgical or obstetric complications, trauma, and neoplastic disease. Now, what is important, another thing is to take a history of cyclosporin A drug, which can cause a drug-induced hypercoagulable state in individuals of SLE and can precipitate an acute event. And of course, lastly, the management. Of course, the hydroxychloroquine is the mainstay for managing SLE patients. And if we have an acute event in SLE, then they can be managed with an intravenous methylprednisolone followed by oral steroids, along with various immunosuppressants. As far as the ocular management is concerned, well, of course, you are going to manage an acute event like CRAO with paracentesis, with Dimox. But if you have late complications like neovascularization or extensive CNP areas, where the patient is not ready to come back for a regular follow-up, you may opt for an early laser and an anti-VEGF treatment. So thank you so much. These are my points which I wanted to highlight.
Thank you, Manisha. Subina, there is the compliment for you from Dr. Shikha Singh in Dubai. She says a very interesting case indeed. And the case, of course, is very interesting and very challenging. And Manisha has already described in detail how to manage. I think one important thing is to keep HIV in mind as well, because Rima had something like this. And that patient eventually turned out to be HIV positive and had no other manifestations. So, Rima, would you like to comment?
Yeah.
Yeah.
Thank you, ma'am. So we had a similar kind of presentation. A very young boy, about 21 years, came with similar kind bilateral The only difference was it was a complete CRVO and CRAO in both the eyes. And he had no history, nothing, no lesions. And it's just that because he was so bad, we admitted him and got a multidisciplinary consultation. And first it was detected that he was HIV positive. His CRP and everything was just normal. And his from HIV, we got the history of low fever since 3 to 4 months, and then low backache, which came upon prompting. So there was nothing active that was going on. And then on general examination, his lymph nodes were found, and biopsy showed that he had, TB all over. So this was HIV detected after ophthalmic presentation, and then TB, and then we couldn't do anything with the eyes. He was just hand motions and light perception.
I think that, yes, sir. So you are muted. You have to unmute.
May I ask some question? I
Sure,
think this is a serious situation we are dealing with it. Is it always like bilateral simultaneous? That is first thing, because I think we do see in another like giant cell arteritis, and we have something more like where we can help the other eye by starting steroids in time. But here, is it always that it comes up like a bilateral simultaneous? Is there any preventive thing? I think that is what is going to be very important from my point of view, because it is serious that if we lose both the eyes, it will become very, very difficult later on. So these are a couple of questions.
I would comment on this. It wasn't exactly simultaneously. She did have a gap of 1 day or so. She says, well, it started decreasing in one eye. I ignore, and she came when it was bilateral. So that was probably 1 day gap. We could have probably started steroids at that time. In India, we just don't take it hota hai types. So she probably didn't act very fast. So I think that could be the reason, because we people are quite casual about our symptoms. So
I think your left eye was probably evolving and it might have gone full flow,
yeah.
But I agree. It needs to be intervened very, very fast. And like Manisha showed, many of the diseases are actually immune mediated, APLAs, SLEs. And even while you are waiting for investigations, because these investigations take a lot of time to come, I won't mind giving IV methylpred.
Yeah, I also agree, ma'am, that probably I also wanted to highlight that probably Dr. Subina could have plunged into an IVMP in this particular young girl, because she already had a very severe event in both the eyes. So I think we have to be very aggressive in intervening in such patients.
But I think when our internist saw the patient, we also asked him that it should be methylpred immediately. So he says 1.5 milligram is high. Patient was 40 kgs. So he says 60 milligram I feel is a high dose steroids. And then I went back and read literature. In SLE, they say high dose is 1 to 1.5 milligram per kg. So methylpred, yes, a few people have given. But if you start with high dose, that's also like there are cases which they have done good. They have done well with that.
Thank you. Thank you, Subina. We move on to our next set, Case of Vitreous Hemorrhage by Dr. Mohit Dogra.
Are the slides visible?
Mohit, they were visible. Now there is something they've got tilted. Yeah, now it's better. Just
Okay.
go to slideshow.
Yes, ma'am. Yeah.
Perfect.
Great. Thank you. Thank you, ma'am. So good evening, everyone, and thank you to COS and to Dr. Chintan in particular for giving me this opportunity. And in stark contrast to the great case presented by Dr. Subina, my case is going to be routine, not even 1/4 as interesting, and just 4 slides. And maybe we can have a big discussion after that. So here goes. It was basically a 28-year-old male who presented in June of 2018 with complaints of sudden painless vision loss in his right eye, which was of 20-day duration. And there was no history of any ocular trauma or any systemic illness. The visual acuity at presentation to us in the right eye was hand motions with an accurate projection of rays in all 4 quadrants. The left eye was fine. The anterior segment examination was normal in both eyes. There was no neovascularization of the iris or elsewhere, and the pupillary reactions were also okay. There was no semblance of an afferent pupillary defect. The fundus examination, where the crux of this presentation lies, actually had dense vitreous hemorrhage in the right eye. Media clarity was grade 4, red glow. The left eye was absolutely normal. Again, there was no issue of trauma, no systemic illness. And once you see a young patient with that what seems like, at least on the outset, and a cursory history taking, very dense unilateral vitreous hemorrhage, you want to rule out certain things. So excessive coughing, constipations, these particular targeted pointed questions were asked, and they were all negative. These 3 investigations this person was carrying with him when he came to us. So he had a absolutely non-reactive 0.012. The TPHA and the HIV were again negative. Chest X-ray was normal. So, as is the dictum, when you can't see the retina, you need an imaging modality to look at what's happening at the back of the eye. So that's the right eye, ultrasound. You can see that there is no PVD, the retina is on, and just anterior to the optic disc, as is highlighted by that, red arrow. It looked like a flat peripapillary oblique macular FVP because, the vertical and horizontal axial scans, we were able to make out that this kind of flattish hyperechoic sheet kind of extended all over the disc and also over the macula. And you could see that there was hemorrhage, right above it. So keeping all of these things in mind, these were the clinical differential diagnosis at this point in time. A vasculitic VH, which is, vitreous hemorrhage, was the first differential. Although, my targeted questions regarding coughing, straining, constipation, any other, the time duration when the vision loss occurred, it wasn't like he was in a gym or, he was doing some of these pranayams or yogas in which the intrathoracic pressure goes up. But still, you can never rule out a Valsalva related vitreous hemorrhage. That was the second DD. And again, no history of trauma, but young active individuals, the traumatic vitreous hemorrhage is something you must keep in mind. So these were the differentials, and keeping in mind the density of the hemorrhage and the fact that what I thought on USG was a flat FVP happening. I subjected the patient to a 25 gauge PPV, and I had a video, but again, this is, I don't think, the forum for it. So just we'll get down to the crux of it. So intraoperatively, there was no PVD. There was pretty dense red vitreous hemorrhage, and there was a flat FVP, which kind of confirmed our preoperative ultrasonographic findings over the posterior pole, and there was a occluded there were multiple occluded infratemporal retinal venules, multiple NVEs in that quadrant, and thus confirmed the diagnosis of occlusive vasculitis. So this is my second last slide. So the patient actually, this is 6 weeks post PPV. The patient had an acuity of 6/18. You can see the right eye has a little bit of a temporal disc pallor. You can see that there's a little bit of a temporal disc pallor. There's also, you can see those pigmented laser scars just, adjacent to the infratemporal arcade. And there are also those occluded vessels which can be seen. The foveal contour is fairly normal. Although there are a few microcystoid changes just temporal to the fovea, and just temporal to the fovea, and there's a semblance of maybe a hyaloid remnant or early ERM formation there. And so, we subjected this patient also underwent angiogram at that point in time. The left eye was unremarkable. The right eye also, I've just put the posterior pole photos, but even the periphery, there was no evidence of any activity, no other area, capillary non-perfusion area, no NVEs to note of, and there was just some staining of the perifoveal kind of the capillary bed in the late phase, and that was pretty much it. And maybe a little bit of that those microcystoid changes temporal to the fovea, maybe we can correlate them a little bit with whatever seen there, but essentially no signs of activity. And the patient was just treated with, at this point in time, after 6 weeks, just with topical non-steroidal anti-inflammatories for the microcystoid edema, and has continued to do fine. Thank you.
Thank you, Mohit, for a very well illustrated and very simple case. We can have short comment by Ravinder and then we can take up the questions.
Hello.
Hi, Ravinder, we can hear you.
Yeah. Thank you, Mohit, for presenting a beautiful case. Actually, this is for comprehensive ophthalmologists, and generally they come across with such patients only. So, idea of presentation is to see how to tackle a case of vitreous hemorrhage. So, I'll be taking a few other causes also, which they need to rule out whenever they see a case of vitreous hemorrhage. I'll be sharing my screen.
Mohit, yeah.
I've just stopped sharing now.
Absolutely. Thank you. So I think Mohit mentioned it very clearly that many a times all you need is vitreous surgery to clear the hemorrhage. So don't go overboard investigating a case of vitreous hemorrhage if you are not seeing anything in the opposite eye. So on to you, Ravinder.
I hope screen is visible.
Yes, go to slideshow, please.
Yeah. Is it okay?
Preferably slideshow, Ravinder.
Okay.
Okay, it's fine otherwise. Just go on. Yeah, this one, slideshow. Yeah,
Yeah.
perfect.
So, in Dr. Mohit's case, it was a young patient who came with vitreous hemorrhage, and no clue was available in the other eye. Otherwise, wherever possible, we look for, especially in the extreme periphery, to rule out areas of vasculitis so that we know what is the reason in such young patients. Otherwise, what other etiologies that can lead to vitreous hemorrhage generally are most common we encounter is proliferative diabetic retinopathy followed by vascular occlusions, and very commonly in older age we see acute PVT with either vessel avulsion or retinal tear. Trauma, if it is there, is obvious, and uncommonly we see proliferative retinopathies related to sickle cell retinopathy or blood dyscrasias, but very commonly in young patients, Eve's disease kind of picture is relatively common whenever we encounter vitreous hemorrhage. If there is evidence of uveitis, obviously there could be presence of peripheral neovascularization, which would have led to vitreous hemorrhage. So how to go about in a case of vitreous hemorrhages? First, we have to try to see the periphery with the indirect ophthalmoscope. If otherwise it is not visible, for any clues, especially look for neovascularization of iris, gonioscopy, and rule out increase in intraocular pressure to have some clue regarding occlusion or neovascular glaucoma, and then any evidence of uveitis in the anterior segment or in the other eye. If there is no view, then we need to do B scan to rule out RD or PVT. If there is RD, obviously a patient needs urgent surgery. If there is no RD and vitreous hemorrhage is significant, we can wait for maybe a few days, and if it starts settling down, then we can see and look for any presence of any tears. In the meantime, we can do basic blood investigations and advise general like advise rest and head elevation, although it doesn't have that much of role. But even after a few days, we do V scan, and if there is no RD, we can wait. And after a few days, we repeat V scan if there is still no view. And if there is no RD, we can try intravitreal anti-VEGF if the patient has signs of history of diabetes or systemic hypertension or ischemic heart disease. We look for clues in the other eye, and accordingly we treat. After intravitreal Avastin, if the media starts clearing, then we try laser if it is related to diabetes or hypertension. Otherwise, we go for vitrectomy. So I'll be showing few case scenarios which will clear the picture. Like generally, we have a scenario which is most common is a patient above 50 years, especially myopic, if presents with the sudden onset of flashes followed by floaters. This is the most common scenario, and the other eye is normal. Most likely it is because of acute PVD with vessel avulsion or retinal tear, with or without RD. And we see the periphery and do a B scan, and then accordingly we treat further. Very important is to not to inject any eye with vitreous hemorrhage without knowing the cause. So this is one such patient where there is vitreous hemorrhage, and he underwent vitrectomy, and we could see peripheral tear with the localized RD. This is an important slide I want to share definitely, because this patient had marked vitreous hemorrhage in one eye, other eye was normal, and he went to some other place and they advised injection Avastin. And as the patient could not afford, he came after 2 days to me, and I could see a giant retinal tear which was already extending more than 180 degrees. So since I advised urgent surgery, patient was confused that there is so much of difference between two opinions. So he did not turn up for the next day, and after 2 days he came with 360-degree giant retinal tear. So of course after surgery he improved, but the point of showing this case is for general ophthalmologist, comprehensive ophthalmologist, that not in every patient of vitreous hemorrhage we should inject anti-VEGF without knowing the cause. So that would have extended it further. This is second scenario where the this is a patient, if generally patient of 50 years or so, and is a known case of hypertension or diabetes or ischemic heart disease, presents with vitreous hemorrhage, and the other eye is absolutely normal or shows some arteriosclerotic changes, then there is possibility of branch retinal vein occlusion, which might be there for a long time and patient might have missed until the patient has bled from neovascularization, raised fibrovascular proliferation. So in these cases, very important to rule out neovascularization of iris. And obviously, if the other eye is showing signs of diabetic retinopathy, then the things are very clear. This is one such patient, 48-year-old female presented with vitreous hemorrhage, and she improved little bit, and we could do angiography, and you can see she has 6/6 vision and total superior occlusion. After a few days, she had recurrence. Even we started PRP, but she bled again and underwent vitrectomy. So it is possible that even with good vision, they can have peripheral occlusions. This is the third scenario, like Dr. Mohit has discussed, young patient coming with vitreous hemorrhage, and there is possibility of inflammatory etiology or trauma or Valsalva or any blood dyscrasias. So examination of the periphery is very important, and in such patients, after investigations, we can go ahead with vitrectomy if the patient is not improving, and then they need long-term treatment in the form of steroids or immunosuppression, and examination of the other eye is very important, and long-term follow-up very, very important. This is a young patient coming with vitreous hemorrhage in the left eye. Right eye was showing evidence of healed multifocal choroiditis, and the left eye you can see the anterior segment shows posterior synecdoche, and she underwent vitrectomy because the hemorrhage was not clearing. She had peripheral TRD. So at the time of silicone oil removal, Ozitex implant is there, and she needed long-term treatment with steroids and immunosuppression. Another patient, young patient, 22-year-old female, again presented with bilateral vitreous hemorrhage, and in the periphery we can see areas of frosted branch angiitis. This was possible to see even through dense hemorrhage, and we could see that this is a very, very complicated situation, and we need to really these patients for comprehensive ophthalmologists are not easy to manage. They need to be referred immediately to the tertiary care centers, because here the total vision can be lost within few days. So this patient is maintaining well even with the medical treatment in one eye, and the other eye required vitrectomy. Scenario 4 is an elderly patient comes with or without systemic disease, presents with vitreous hemorrhage, and has neovascularization of iris, although other eye has no signs of any diabetic retinopathy or hypertension, but he straightway presents with neovascularization of iris and high pressure. These patients need to rule out ocular ischemic syndrome, and carotid vessel disease need to be ruled out. These patients can present with featureless kind of retina, pale looking, and they can have peripheral retinal hemorrhages, present with neovascularization of disc, or in addition to NVI and vitreous hemorrhage. And FFA gives clues to the diagnosis, and they need extensive carotid workup as well as urgent PRP and anti-VEGF. This is the fifth scenario where the elderly patient comes with vitreous hemorrhage and no systemic disease, and other eye is showing some signs of VRMT, and in such patient there is possibility of PCV. B scan is very important, and one such patient, 70-year-old patient, presented with vitreous hemorrhage in the left eye, and on B scan we could see mounds of vitreous hemorrhage and with subretinal bleed. Possibility of PCV and masquerade syndrome was there, and he underwent vitrectomy, and you can see there was marked areas of subretinal bleed, and old and fresh hemorrhage was there. So ultimately improved after giving multiple anti-VEGF injections and vitrectomy. So less common causes of vitreous. Yeah,
Ravinder,
I can conclude. Yeah. So some of these patients can present with trauma and Turson syndrome. These are just to enumerate, so that general ophthalmologists should have some picture in their mind when they see a case of vitreous hemorrhage, that these are the pathologies which can be there. So knowledge about various causes can give clue to the diagnosis, and proper history and proper investigations, detailed examination saves unnecessary investigations. So treatment should be directed at the cause of underlying cause. Thank you, ma'am. And
thank you, Ravinder. That was very clear and very exhaustive. This question for Mohit. Mohit, how would you manage a young patient coming with unilateral vitreous hemorrhage? This is the question. Like, what algorithm would you follow? Other eye normal.
Absolutely. So I think, ma'am, it's fairly similar to the case that actually I presented, and I think, and I think as Dr. Ravinder ma'am has very elaborately, kind of enumerated the causes, the etiology of vitreous hemorrhage in the younger individuals as compared to the not so young is different. So in younger individuals, one would, and this is prior to any investigations, just based on the history and a clinical exam as to whether the fundus is visible, whether it's a very dense hemorrhage or there is a glance of the peripheral retina that one can see, because a PVD would have either not occurred at all or would have just very partially occurred in a particular area. So it's possible that you might have a very dense hemorrhage covering the posterior pole and maybe extending all the way up to the equator, but the periphery is still kind of visible if you were to do an examination, which could give you a clue if you can see a occluded vessel or a sheathed vessel, as in one of the cases ma'am had shown. Which could give you a clue as to what the etiology is. So just quickly summing up, I think in in young individuals in which the fundus is not visible because of vitreous hemorrhage at presentation, unilateral, and keeping in mind that the other eye is absolutely normal and not giving you any clue, I think a vasculitic vitreous hemorrhage, Valsalva related event which might have caused a vitreous hemorrhage, and that could happen after in a lot of scenarios. So people could be constipated, there could be chronic cough, more commonly people could just be lifting weights, be in the gym doing some of those yoga or pranayams in which the head level is below the body level, and the
Viagra.
With them Viagra as well, but again I think with younger people that might be a little so I think Valsalva is something which is right up there. I think right secondary to vasculitic vitreous hemorrhage. The other is also Turson's, but Turson's, the kind of the premonitory symptoms, the premonitory kind of environment would be different. There would be a neurological event prior to that. The patient might not, most likely will not present to you, will be referred by the neurosurgeons or the treating neurologists. But that is something that could occur. And the fourth is just trauma. Young people can get close globe trauma, and so I think one thing to be kept in mind is that a lot of these retinal vasoproliferative diseases, which typically are the cause of vitreous hemorrhage in the elderly, are not the cause in the young, except vasculitic vitreous hemorrhage. So just injecting anti-VEGFs without knowing what it is not the way to go. And if the other eye is not giving you any clue, and you know that it is, and you're sure it's not a traumatic event. So you don't know whether if it's a traumatic hemorrhage, I think you can watch it and just observe it with ultrasound. If there is no retinal detachment, because it's a one-time event, it could and it should kind of abate of its own. But if you don't know the cause, it's non-traumatic, young patient, it's unilateral. In today's day and age, I think it's best to get the hemorrhage out so as to get a good view at the retina and then tackle it as and when what lies beneath.
So the take-home point from this beautifully illustrated case is, if you have a vitreous hemorrhage, especially in young, it's better to get an ultrasound, look for detachment versus no detachment. But either ways, there is no point in injecting or in doing lasers or getting the exhaustive investigations. It's always better to refer to a retina surgeon and do a vitrectomy. And if it is elderly patient, like Dr. Ravinder showed beautiful illustrations, then depending on the etiology that you think it could be, you could move forward. Thank you very much, both of you. And with this, I would like to invite Kanika to present a case scenario of choroiditis.
Good evening, everyone. Thank you to cause Dr. Chintan and Dr. Vishali. I'll be, are my slides visible? Are my slides
Yes, Kanika. Yes, it's perfect.
So I'll be heading to my case. This is a frequently encountered scenario in our clinics where we have to use clinical examination as well as imaging tools to arrive at the correct diagnosis. This was a 32-year-old male who presented with chief complaint of diminution of vision in the right eye of 1 day duration. This was sudden in onset and painless, and the patient was a chronic smoker. On examination, his best corrected visual acuity was 624 in the right eye and 66 in the left. His intraocular pressure was normal. Anterior segment was within normal limits in both eyes, and posterior segment was normal in the left eye and the right eye. We'll see in this photograph. So the right eye media clarity grade 1, and there was presence of this faint yellowish subretinal lesion with fuzzy margins, and there was presence of fluid in the macula, which was in a cystoid kind of a configuration in the fovea and also here below near the arcade. And at the outset, just felt that this could be fibrinous CSC until we looked into other imaging modalities. So this is a EDI OCT scan passing through the inferior part of the macula. And here we can appreciate the choroid appears to be thickened, and there is this area of homogeneous, nearly homogeneous hyporeflective oval lesion in the stroma, and there's presence of subretinal fluid. Now going higher up towards the center, you can see this intraretinal fluid in a cystoid configuration, and outer retinal layers, the ELM, the ellipsoid zone, interdigitation zone, they appear to be disrupted. And the choroid is it's visibly thickened. It was 586 microns in this particular section, and the section passing right through the fovea is showing intraretinal fluid. And now if we look at these features like pachychoroid, like a thick choroid and presence of intraretinal fluid and subretinal fluid, then a diagnosis of CSC comes to the mind. But if we look more carefully, then we can see here in the topmost scan that the myoid layer is split. So if you see here, the ELM and the inner segment myoid is forming the roof of this cystoid collection of fluid, and the floor of this cystoid collection of fluid is made up by the disrupted ellipsoid zone and the interdigitation zone. So this is known as bacillary layer detachment, and it has been a recently described entity in certain inflammatory pathologies such as posterior scleritis and VKH. And so we went ahead and we did FFA, which showed presence of a hypofluorescent lesion in the macula, which is more clearly appreciated in the arteriovenous phase. And in the later phases, late venous phase, we can see that the lesion becomes less hypofluorescent with surrounding hypofluorescence. And in the in the recirculation phase, we can see multiple pockets of pooling of the dye. So there was no focal leaking point or any expanding dot or a smokestack pattern, which we expect to see in a case of CSC. We then did a ICGA, and which showed presence of these hypofluorescent lesions, multiple lesions we can appreciate in the macula, which remained hypofluorescent in the late phase as well. Again, there was no focal or diffuse hypersenescence or hyperfluorescence, which should be there in a case of CSC. So what were the points in favor of CSC in this case? A pachychoroid, a thick choroid on OCT, subretinal fluid on OCT, and pooling of dye, which was seen in the late phase of FFA. ICJ did show a large vessel, but that is not a very specific sign. So these were the points in favor of CSC, but there were various points going against CSC, which is that a thick choroid does not necessarily mean a CSC. There's an expanded spectrum of a thick choroid, and even choroiditis and inflammatory posterior segment pathologies can be associated with a thick choroid. Then a bacillary layer detachment, which I described, has been has not been described in cases of CSC. It has been associated with inflammatory pathologies. There was no definite leaking point on FFA. And ICG particularly showed early and late hypolesions, which goes in favor of a diagnosis of a choroidal granuloma. And there was also no classic descending track, the RP tracks that we see in cases of CSC. So based on multimodal imaging, we diagnosed the patient as choroiditis. And we did lab investigations. The MON2 was positive, 13 by 13 millimeters, although quantiferon TB gold and CECT chest were within normal limits. The ESR was raised and VDRL TPHA was negative. So the final diagnosis was right-eye tubercular choroiditis. And now with the COTS group coming up with the standardization of nomenclature for various phenotypes of TB choroiditis, this case fell under the category of a tuberculoma. So we had a recent publication on tubercular choroidal granuloma showing bacillary layer detachment on OCT. So this is a good sign to look for if you're trying to differentiate an inflammatory pathology from a non-inflammatory pathology. So as far as treatment is concerned, he was started. Now this patient had one immunological test positive. The radiological test was negative. So based on the COTS guidelines, this case fell under the category of a moderate consensus to start ATT. Now, when we started the patient on oral steroids, he showed a very good response, a very early response, and lesions started healing very fast. So we did not start ATT for this patient, and all lesions, they healed within a month, and his visual acuity was restored to 6.6. So this is in February 2018, 1 month after starting oral steroids. Now the disease remained quiescent for 2 years. And again, in Jan 2020, he presented with diminution of vision in his right eye. Vision had again dropped to 624. The anterior segment was quiet, and posterior segment showed this yellowish subretinal lesion. This is kind of a multilobulated lesion in the macula, and there was presence of fluid clinically. And on OCT, we can appreciate this choroidal bulge, this RP elevation, along with presence of this homogeneous hyporeflective oval looking lesion in the choroidal stroma, which is characteristic of a choroidal granuloma. And there is presence of subretinal fluid. So at this stage, we did a combined FA-ICG, which shows a hypofluorescent lesion on FFA, and the ICG is better showing the hypofluorescence. It's more clearly defined in the ICG. And in the later phases, the lesion can be seen as a multilobulated hypo lesion on ICG, and the FFA is showing subsequent, the lesion subsequently becoming isofluorescent and hypofluorescent. So this is the late phase of FA and ICG for this choroidal granuloma. So the patient was planned for left eye injection of ranibizumab, followed by oral steroids and ATT. Ranibizumab, as we know, is a useful adjunct to systemic therapy in patients with choroidal granulomas. And there have been publications by Dr. Rima ma'am on this particular topic. So 3 weeks after intravitreal ranibizumab and ATT and steroids, the patient's visual acuity returned to 6.6. His foveal contour normalized, and we can see the granuloma has disappeared. And the patient has now completed follow-up of 6 months after starting ATT. He's on 2-drug ATT now, and he's maintaining visual acuity of 6.6, and he's off oral steroids. So that's my case. Thank you.
Can we have Rima's discussion, and then we can take it forward? While Rima is putting slide, Mohit, there is a question for you. How long would you wait for spontaneous clearance of vitreous hemorrhage?
So again, ma'am, that's a very open-ended question. It depends on what the age of the patient is, what the etiology is that I am suspecting, what the fellow eye status is. So if let's say if it's a lasered proliferative diabetic retinopathy patient that either is carrying records or I lasered myself and was doing fine for some time and has bled, in kind of front of my eyes. Then, of course, I would wait a lot longer. And, again, depending on the quantum of the hemorrhage that there is, and not want to, but again, if it's a young patient coming back to, and if the etiology is in doubt, and keeping in mind that in younger individuals, those vasoproliferative kind of causes of vitreous hemorrhage are only one, which is the vasculitic vitreous hemorrhage, which if you wait and it's not lasered, obviously, then it will lead to early formation of NVIs. So again, it's a very difficult question to answer, only because it has lots of permutation combinations. It's case specific, age
But by and
specific.
large, I think if you cannot see the retina and it's dense hemorrhage, you go in.
Yeah, absolutely, ma'am.
Absolutely.
In a virgin eye, I think we should get into the
We
eye
should go
rather
in.
than
Yeah.
yes, ma'am.
Okay. Yes, Reema, are we ready?
Yeah. So I have not made any separate slides for that because I thought this case needs to be discussed based on imaging.
Yeah.
So can you see?
No, share your screen. Go to share screen. There is this green icon at the bottom. Yeah, we can see it now. Perfect.
So thanks, Kanika, for bringing this case out, and very well managed, and teaches a lot of lessons to us. So the first thing that comes to your mind when you see this kind of exudative detachment in especially unilateral, I think when we think of acute CSC, we also think of an inflammatory cause, and which you did, and turned out to be TB choroiditis. But many times with this kind of OCT finding that you showed, okay, so a lot of people think of acute VKH also, and especially with bacillary layer detachment, I think that is the first thing that comes in mind. So, but classically, the angiogram and the ICG shows only dye pooling, which is suggestive of there's some exudative process going on. And plus, if you look at the ICG, there are no granulomas that we see in VKH, widespread granulomas. So rightly said, it's a case of stromal choroiditis secondary. So we just need to classify whether when you're seeing a choroiditis, whether it's an inflammatory choriocapillarypathy or it's a stromal choroiditis. So from this kind of exudative phenomenon, we are dealing with a stromal choroiditis and not the inflammatory choriocapillarypathy. When it comes to stromal choroiditis, we think of primary and secondary. So primary includes VKH and sympathetic ophthalmia. Secondary is because of TB and sarcoid and so on. So rightly managed, because you had some evidence of positive tuberculin skin test, probably the patient recurred because the patient did not receive ATT in the first go, and we keep our fingers crossed with the next follow-up that we've given ATT, we've given anti-VEGF, and we hope the patient does not come back with recurrence. And second thing I would like to point out is bacillary layer detachment. Now the concept is evolving more and more, but it's not really completely a sign of an inflammatory pathology. We do need to keep in mind, because if you see the series by the Italian group, they have noticed it in pachychoroid, they've noticed it in choroidal osteoma with the CNVM, and they've also reported in choroidal metastasis from lung and breast carcinoma. So by and large, yes, we do think of inflammatory disease, but these things also need to be ruled out. And as rightly pointed out by you, it was not CSC because of so many findings on the FFA and the ICG. So thanks a lot, very nicely managed, and hope this patient does not get a recurrence because if he completes the ATT.
Thank you, Reema. That was absolutely clear. Manisha, is Manisha around?
Yes, ma'am.
Would you like to comment?
No, I think ma'am Reema has covered it all. So I don't have
Yeah, I think the important point to remember here where we went wrong is TB responds to anything like steroids, anti-VEGF. So when you give and the patient starts responding, you kind of get this elated feeling that patient does not need anti-TB drugs. Like we had started treating granulomas with anti-VEGF, but now when we see them 2 years, 3 years down the line, they do have recurrences. So that is why we have this consensus that if the tests are coming positive, you do need to give ATT to prevent recurrences, but the immediate treatment can be with steroids or with anti-VEGF. So now moving on to something simpler, which is Dr. Anirudh Agarwal, and everybody sees that is CSME and diabetic retinopathy. Anirudh?
Very good evening. Thank you, Kos, for this opportunity. Thank you to Dr. Chintan and Dr. Vishali ma'am for this opportunity. I'll just go ahead and share my screen. Are my slides visible?
Yes, go on slideshow.
Yes. So I'll be discussing actually a very simple case of a patient who comes to us almost day in and day out in our clinics, of a patient with diabetic retinopathy with diabetic macular edema. So going straight to the case, we have a 53-year-old male who has been referred to us by an endocrinologist for fundus evaluation and was diagnosed with diabetes mellitus type 2 10 years ago. The patient was on irregular follow-up with the endocrinologist with chief complaints of blurring of vision in the right eye for the past 1 month. In the right eye, he was seeing 6/18 and the vision in the left eye was 6/9. The anterior segment examination did not show any iris neovascularization. And since this is for the comprehensive ophthalmologist, I would like to stress upon the INVs because often we get patients in whom we may not have very impressive posterior segment findings, but this is something that we need to focus on. And you may have angle neovascularization or iris neovascularization in these patients. This is the fundus image of the patient of the right eye, which shows us presence of hard exudates right in the center. And there are microaneurysms which are involving just near the foveal center. The left eye is slightly better, where you have fewer hard exudates which are involving the center of the macula. And I just wanted to include this slide to show us that in patients with DME, diabetic retinopathy, this is the classification that we usually follow. We'd like to look at the microaneurysms, and if there are only microaneurysms, we call it mild NPDR. But this patient clearly had more than microaneurysms and had hard exudates, and so comes under moderate NPDR. I would also like to highlight what is called as the OCT-based classification of DME, which is not based on CSME, and which essentially means that this is something that we follow nowadays in our clinics, where we would like to call the edema as either center-involved DME, when it is involving the central 1 millimeter, pericentral inner involved DME based on the ETDRS inner circle, or pericentral outer involved DME. Based on the amount of edema, we can call it, we can quantify it based on the thickness, volume, and looking at the other parameters of these subfields. We also look at various vitreoretinal interface abnormalities, such as epiretinal membrane, posterior hyaloid detachment, if they're present, absent, or incomplete, and presence of hard exudates in the central subfield. Now, hard exudates is something that has been recently shown to be very important in the prognostication of patient and in the decision making for the use of therapeutic agent in these patients. The fluorescein angiography in these patients, I think at baseline is very important because it tells you the location and presence of the microaneurysms and whether they're leaking or not. As you can see in this patient, there are certain microaneurysms which are very near the foveal center and some of them are slightly away. And it's important to follow them in the late phase, and you realize that not all the microaneurysms are leaking in the late phase. And these are the microaneurysms that you would like to identify and treat if you're going ahead with focal laser. But in this particular patient, you can clearly see that there is significant leakage in the center, and probably on the OCT, you are expecting a significant thickening. Sure enough, you also are going to obtain peripheral fields to see if there are any NVE which may be occult and which you may have missed clinically. The left eye also has microaneurysms which are closer to the center, and these of course are leaking in the late phase. The OCT, I'm just showing the right eye here because that's the eye of interest, and you can see that there is presence of hard exudates which look like these hyperreflective dots in the center. Now, if you exactly are able to co-localize these hard exudates in the center, then you would realize that some of them do not correspond to the hard exudates. And these are actually called as the hyperreflective foci. So hyperreflective foci are those hyperreflective dots on the OCT which do not exactly correspond to the hard exudates. In addition, you have cystoid spaces which are also involving the outer layers, and you have a very much an intact outer retinal layer, including the RPE, the photoreceptors are all intact, and the inner retinal layers, you are able to identify all of them individually. And so I can confidently say that this patient does not have drill or what is called as disorganized inner retinal layers. Similarly, this patient has an intact outer retinal layer and the ellipsoid zone, the photoreceptors. Now, of course, when you treat these patients, you would look at this image does not belong to this patient, but it's just to show that you can use fluorescein angiography to actually follow up these patients and see for the improvement in the microaneurysms. And of course, you can use your OCT angiography to detect microaneurysms, although OCT-A is not a great tool for microaneurysms, but rather for the avascular zone. You can also look at the fluorescein angiography at baseline to determine whether there is presence of macular ischemia. As far as investigations, these are the panel of investigations that we would like to get done at baseline. And among these, the most important ones that I feel I've highlighted include the HbA1c, the cholesterol levels, hemoglobin, triglycerides, and 24-hour urine protein, which give us the systemic control of these patients. And sure enough, this patient has a deranged systemic profile. So apart from treating the ocular disease, we are going to treat the systemic condition in this patient with lifestyle modifications, metabolic control. And this patient, we decided to use anti-VEGF therapy. With ranibizumab, left eye did not have edema, so was kept under observation. And often we start our patients with atorvastatin, especially if there is hyperlipidemia, to take care of the systemic control. And this is the follow-up OCT of this patient, and this patient actually did well. And we can go back and actually see that this patient had an intact inner layers and outer layers, and probably this is why this patient actually probably did well compared to a lot of other patients that we see in our clinics. Thank you very much.
Thank you, Anirudh. We now have Dr. Dogra, who will be commenting and giving the tips for a comprehensive ophthalmologist to approach a patient of diabetic macular edema.
Sharing me.
शेयर करना है ना तो ये दबाओ शेयर दबाओ
सर आपकी डेस्कटॉप शेयर हो रही है आई थिंक
ये दबाओ स्लाइड शो करो
एक मिनट जस्ट अ मिनट स्लाइड शो नो ये तो पूरा हुआ गया yes. Okay. Sorry. A little bit.
That's fine.
Yeah. I think Anirudh has presented a great case. I think from the point of view of comprehensive ophthalmologist, I think I'm just going to be very basic, and he has discussed most of the points. So we have here 53-year-old male, irregular treatment, 10 years diabetic, 6/18 in the right eye. And he has described all the features there. Only thing is on OCT, what he was trying to say about the hyper-reflective dots, I don't know, I'm not sure, because everything is showing sort of a shadowing behind. So maybe these are all perhaps hard exudates there. And the left eye, of course, is something, I mean, which is he has already described, and it is, of course, I think he categorized it very well. The first thing for anybody, whenever patient of diabetic retinopathy is seen, is to categorize, and which he did very well. And we have to kind of be very clear here that these days we use these terms. So right eye had a center involving diabetic macular edema, and left was non-central involving diabetic macular edema. And he did all the investigations, whatever I have listed here, and that includes both systemic as well as the ocular ones. I think only thing, I don't think he mentioned about the blood pressure. I don't know if he was hypertensive. So I think that point we can take later. And what is important here is, whenever we want to interpret a angiogram, we also need a fundus photograph, because I think don't do it independently. This is for any comprehensive ophthalmologist. So must look at the fundus picture or the fundus itself and then interpret it. And early and late pictures are very important. That is what he had shown, and nicely shown that how the leakage or the diffuse leakage or CME is seen, which was also demonstrated nicely on OCT picture. And in the left eye, you can see again here, you have these focal leaks, and they are away from the center. And here again, you can see that these are leaking in the late stage. And so he has presented these investigation. That means patient is not anemic. He's poorly controlled. It's very important. And HbA1c is also 9 and is dyslipidemic. So these are the major issues. So you need to take care of all these things. Achieve an excellent glycemic control. It will be very important in this case. And also reduce the serum lipids, because he has a dyslipidemia. And of course, the treatment here, primary treatment, is intravitreal anti-VEGF with or without deferred focal laser. I have put it here because I think I'll come to it later on, that we have a lot of difficulties as far as the treating our patients are concerned. They come from all different strata of society. And I think if we go according to this, what DRCR network has shown us, so first year only you may need 8-10 injections, next year maybe 3-4, and the third year it may go down to maybe anywhere from 1 to 3. So, but many of our patients, they won't be able to sort of be in this group. There can be a problem. And if there was an ideal situation, patient is very well off. Now, this is the patient which falls in a group where probably, because this is less than 20/50, 6/18 visual acuity. So ideally, according to this study, we could have started Eylea. But I think did very well with ranibizumab. And obviously that is according to the study, what has been mentioned here. And what is very important to keep in mind for everybody here is, don't even go for any intervention, even if you have a center involved diabetic macular edema and you have normal visual acuity. In those cases, even 6/9 for that matter, that's fine. It is less than, it has to be less than 6/9. Then you just, the three groups where the Eylea laser observation was done, they did equally well at 2 years. So the observation is best mode, and do at that time a good metabolic control, so they would not deteriorate if the visual acuity is normal. So we need not put these patients on treatment. That's very, very important. And this was from the protocol V, which we learned and got published in April 2019. Suppose this patient has a cataract. That is what the comprehensive ophthalmologist is going to be interested. And if he has a cataract and he wants to remove, I think this data is very important here again. Of course, we knew right this from olden times when the ETDRS study was published, that here, even now, if the patient has a moderate and severe and they are at high risk, in 3 to 6 months, they are going to progress. So I think this case was a moderate NPDR and also associated with DME. So this will definitely need then a good metabolic control. Of course, you always use topical, and surgeon should be excellent as far as the phacosurgery is concerned, because otherwise it will be a problem. And you need to avoid multifocal IOL. Don't do those IOLs in these kind of cases. And of course, this is the case where you would definitely need a pre-op or per-op intravitreal Avastin, Lucentis, Eylea, or whatever. If the patient is very poor, may not afford anything, triamcinolone, ideally a Ozurdex, especially in the right eye, and that will be the ideal situation. What I want to say in the end here is that individual pays in India for the treatment, and suppose this patient is very poor, how do you treat it? Suppose he doesn't afford anything, and these days, like in PGI, we have a problem, we can't even use Avastin. So what do you do then? How do you treat this? You're not going to leave him. So that is what the question is. So because of these reasons and so many other reasons, most of the diabetics are undertreated and under-monitored. So we have to understand that they have many comorbid. I think I'll be touching upon some of those things in my lecture also later on. But what is important here is that we have to treat. Even if he doesn't afford anything, sometimes we might even give a triamcinolone 1 milligram or at upper limit 2 milligram and then laser, because you have to project those frames for lasering and do exactly precise laser. That would be in case there is no choice. So don't leave them. That is what is important. So I think these are some of the things which I wanted to mention here, because the treatment would vary, and Anirudh has presented it very well. And I think it's from my side is open for the discussion. Dr. Vishali, please.
Thank you, sir. Yeah, we have a couple of questions for you. Why are we doing 24 hours duration?
Yeah, I think basically, you see, that is the simplest way how you can look at the proteinuria. That's the way I'll put it. Otherwise, one can have estimation of a microalbuminuria also. The question here is that we know that if there is in renal involvement, what is happening? I think is a very important question somebody asked. They'll always do blood urea and serum creatinine. You see, that is the biggest mistake you do. You know, that is a parenchymal damage, which will happen very late. The earliest is going to be microalbuminuria or a proteinuria, which is happening in them. That's why you need 24-hour urine protein. If you are just satisfied with your blood urea and serum, you don't even ask them in the beginning. They come much later when the damage is extensive. So that's why it is so important. And if it can be detected in early stages, we have very good drugs. Send them to your internist, to diabetologists or others, so that they can reduce. They can give also some kind of other recommendations along with the medication that you can help that patient also from that point of view. It will also help the retinopathy as well as the evolution of the nephropathy, which is very, very common.
Thank you, sir. Another question is, focal laser or anti-VEGF, if either one is indicated, which one will you opt?
I think if it is a non-central involving diabetic macular edema, focal laser always. You see, that is the way, because as I mentioned already, why I projected that slide, after all, anti-VEGFs are sort of never ending. And how many you can give? There are other issues. Of course, cost is involved, frequency of visits, and so many other things. So even, I think if you look at many of the trials, there also 35 to 40% of the patient later on has received laser treatment, focal laser treatment. So that is very important. We must not forget laser, although it is advocated maybe more driven by the commercial angle, that laser will not really help, but it does help. In a way, we have seen that laser does dry up all those focal areas. Definitely down the line, you may have, there are certain studies shown where the frequency of injections have also reduced. So I think laser is still got an important role, and it is only a focal laser. We're not talking in terms of grid laser and others. Yes.
And Anirudh, there is a question for you. If visual acuity is good and there is macular edema, how would you plan? Okay, sir. I don't see. Yeah,
this is
can you answer, sir?
if there is a, please.
Visual acuity is good and there is macular edema. How would you plan?
That is what I am saying. Visual, I already mentioned this, that DRCR net protocol, we must go to that. In fact, I think we were always the proponent of that earlier also. I was involved in many times in the national issue, in the debates also on this. You see, if the vision is normal, 6.6, or even it is 6.9, you need not treat even if you have a center involving edema. That is what has been shown very clearly now. They had 3 groups. One was given ILIA for 2 years. Another group was given a focal laser, and third, observation. So all the 3 groups did similar, the observation down the line in 2 years. So don't jump at treatment. In fact, I could have shown a slide or shared a slide here of a couple of patients which we have, where they rather with metabolic control and on observation with better systemic control, they remain good for 2 years. So that is the way I look at it. Yes.
Continuing with that is the question, don't you think laser is more destructive?
Well, I think that's why we are talking here in terms of focal laser, precise focal laser. What you do, you have a good quality angiogram, project it in front of your laser machine, and precisely, mildly treat those focal areas of microaneurysms. If you do that, and you are not anyway coming into the central area, you are away from that. I think we did laser for a very long time. It's not that the laser was bad. It's only thing that we have now pharmacotherapy, which is not destructive, which gives more visual improvement. But this at this time also serves in some of the cases where you have a never-ending injections going on and you have these focal leaks. I think you can definitely help. It's not that it's going to destroy the retina. Don't go overboard, as some of the people, especially earlier on with diode and other lasers, they used to kind of hit retina hard and see those dense scars. And of course, people are doing all these micropulse and other laser, but I have no experience. I can't talk about that.
Anirudh, there is a question for you. When would you do fluorescein angiography in diabetic macular edema?
I think, ma'am, fluorescein angiography is, I think I would definitely get it done. For the first time, I'm seeing a patient at baseline because I would like to assess the macular ischemia. And if I have a patient in whom I'm suspecting if it's a non-proliferative diabetic retinopathy, then my indication to do fluorescein at baseline would be to look at macular ischemia. And if I have a doubt in my mind that there could be occult NVEs which I am not able to see clinically, or if I am seeing irmas and I need to confirm, then I would probably get a fluorescein done. In proliferative...
For macular edema in particular, macular edema.
For macular edema, I think at baseline, it's very important to get it done so that we can decide whether you would like to do a focal laser, as Sir pointed out, or you would like to go ahead with anti-VEGF. I think it's very important to classify the macular edema.
Is that decision based on OCT or fluorescein?
On
center involving versus non-center involving?
Yes, the center involving is based on OCT, but I would like to characterize the leakage, whether it's a diffuse capillary bed that's leaking or whether you have a focal leakage from microaneurysms. And it's very simple. If you have focal leakages from microaneurysms, especially away, then the solution will be focal laser. So I would like to characterize them on fluorescein. So I think fluorescein does have a role at baseline. If Sir has agrees with me, or if Sir has any other opinion, I would like to also.
I think you're right, Anirudh. Baseline fluorescein is already, I think you talked about it. I think it will always be helpful in knowing much more and looking at things which we may not see otherwise. You already talked about microaneurysms. We don't see those focal microaneurysms that many, even if you do OCT angiography. You mentioned that earlier also, as well as we want to look at, of course, OCT angiography may show you macular ischemia, but then at the same time, it will come up very, not only in the central area, which even other area, we need to look at the entire retina. You see, it might be totally ischemic. It might be showing other features, which might have a bearing, because we are not just focusing at just looking at macular edema. It is a disease which is involving so many other things are there. So I think angiography is very important. That's how even wild field angiography, some people advocate because of the peripheral changes which can happen. They can go sometime directly even into a neovascularization. So I think angiography still has a role, but it is not that it is done as often as it was done in past. So that is the difference. I think OCT has come in a big way because we monitor our treatment as well as institute our treatment based on OCT.
The question is especially relevant, sir, because many of the new practitioners actually invest in OCT now and not on fluorescein angiography. So can we decide it based on OCT alone?
I think
And
we should
there
not.
is a question from Dr. Vivek Vani from Belgaum, who says, baseline OCT doing is such a huge burden for hospitals and clinics. Limit it to cases where the visual acuity and fundus do not match. Do you both agree?
No, that's not true.
No.
You see, at this time, we must understand, I think OCT should preferably be done if it is available.
Absolutely.
When the patient has presented to you. You see, sometimes even a totally innocuous looking retina may show so many things which we are not seeing otherwise. And other way around, maybe if you have a visual loss, there might be findings which may explain so many other things. I'm not talking of that. I think the baseline OCT and fundus picture, if we can do on first go, and maybe just give an appointment for angiography, that will be the way to go. But OCT we can't. And even otherwise also, if you are not going to do OCT, how do you plan the treatment? I think a little bit, Anirudh mentioned about it. It's not only center involving, non-central involving. It could be tractional, non-tractional DME, so many other things which are picked up. So I think it's very, very important. Without OCT, it will be very difficult to function at this time. And if you have it, please use it. It is non-invasive, it is quick, and it will serve as a great tool for you for further management.
And Dr. Vivek Vani is saying that if OCT can explain the vision loss, then there is no need for fluorescein. I think Anirudh probably does not agree.
No,
neither
OCT,
does Dr. Dogra.
Yeah. OCT will not pick up like macular ischemia. It will not pick up those dropout areas. Yes, and it will not pick up those microorganisms and other things which Anirudh talked. So I think we have complementary. What we are talking here is we are not using angiography as in past, but primary tool at this time is OCT. That is what is very important from the comprehensive point of view, because that is how you're going to not only subsequently monitor, but if you start treatment, after treatment again, you base it on that as well as monitor on that basis. So how will you do that without OCT? That is not possible. Yeah. All pharmacotherapy, which is the primary treatment these days, it will not be possible without OCT.
So I guess the treatment can be initiated based on OCT if you are seeing macular edema, but somewhere along the point, whenever you can, you should have a good fluorescein angiography to document whatever is happening. Exactly. And if it is only non-proliferative, you're welcome to follow it on OCT unless you see something suspicious again and repeat fluorescein.
Absolutely.
Thank you very much, sir. Thank you very much, Anirudh. And we move on to the last part. Again, something which everybody sees, increased post-op inflammation. Sema?
Yes, ma'am.
Please go
thank
ahead.
you, ma'am. At the outset, I'd like to thank Dr. Vishali and the executive of the Chandigarh Ophthalmological Society, Dr. Chintan, for giving me this opportunity. So I'm going to share a relatively fairly common scenario that we see, that is increased post-operative inflammation following cataract surgery. It has become relatively rarer these days in the COVID times. Not many cataract surgeries are happening, but still we do get to see it and what to do. So this is a couple of years old case. 13-year-old male presented to us with history of decrease of vision in his left eye since 4 months, had a history of low vision both eyes for the last 5 years, but was particular in saying that he is experiencing further decline in his left eye now. And the vision loss was painless and progressive, no history of redness or discharge, no history of trauma or fever. He was a known case of acute lymphoblastic leukemia, diagnosed 9 years back, had completed chemotherapy 6 years back, and was now under remission. Diagnosed with bilateral CMV retinitis during this course and treated for the same. Right eye underwent cataract surgery 4 years ago with a poor visual gain, which was primarily attributed due to retinal causes. And left eye was under follow-up and quiescent for more than 1 year now. So this was the examination at this presentation. Now the right eye had a visual acuity of PL plus inaccurate PR. Left eye was 660. Intraocular pressures was 12 millimeters of mercury in the left eye. The visual axis, there was a right eye exotropia of 45 degrees due to visual deprivation. The extraocular movements were otherwise full. Lids and adnexa were normal. The pupils, the right eye was mid-dilated and non-reacting. Left eye was normally reacting. The right eye anterior segment shows iris atrophy, a decentered IOL, a thick PCO, and a quiet AC. The left eye also had a quiet AC and a posterior subcapsular grade 3 cataract, which you can see. And this fundus photograph, you can see this haze that is there, that is primarily due to the cataract in the front. And we can see some amount of disc pallor, some fibrosis present superiorly, and the peripheral atrophic retina due to the healed CMV retinitis, along with some fibrosed vitreous over it. The right eye did not have any fundus view, so it was primarily a one-eyed patient. The diagnosis of right eye pseudophakia with left eye posterior subcapsular cataract with bilateral healed CMV retinitis. So there was a plan. The plan was to do left eye phacoemulsification with PCIOL implantation to get rid of the media opacity. It was an uneventful surgery, left eye phacoemulsification with capsular bag implantation of IOL, no posterior capsular tear. Sodium hyaluronate 1.4% was the viscoelastic used during the surgery, and povidone iodine 5% was instilled into the conjunctival sac before and at the end of the surgery. This was post-operative day 1. We can see the vision was hand motions close to face. Intraocular pressures were 9 millimeters of mercury. What we see here is an exuberant fibrinous response in the anterior chamber. There was going on higher magnification, we could see some 4+ cellular reaction. And on retracting the lower lid, we can see the streak of hypopyon, which is there over here inferiorly. So there was increased post-operative inflammation. We could not visualize the posterior segment. There was a yellow glow. We did an ultrasound V scan, which shows membranous echoes in the vitreous cavity, which were likely suggestive of exudates, and the retina was on. So exaggerated post-cataract surgery inflammation. The first differential was post-op endophthalmitis. A second lower down was toxic anterior segment syndrome, TAS, or a flare-up of uveitis, which could also present since there was a history of uveitis in this case. So differentiating TAS for endophthalmitis is always the thing that we talk about, and we should always be thinking in terms of endophthalmitis in case of any doubt between them. The timing of TAS usually is within the first 12 to 48 hours, and it presents early. Endophthalmitis may present between 2 to 7 days or later, but sometimes cases can present at day 1 also, especially in our setting where the organisms tend to be more virulent. Pain, endophthalmitis is usually painful. There is lid edema present in endophthalmitis. Corneal edema is an important sign, as TAS usually has a limbus to limbus corneal edema due to the toxicity. And endophthalmitis, it is usually just near the section or thereabout. Exudates, AC, there is a more fibrinous response in TAS, while a hypopyon is largely suggestive of endophthalmitis. And intraocular pressures in TAS, they are usually raised. In endophthalmitis, they may be normal, raised, or sometimes decreased also. Ultrasound is important as in TAS, usually the vitreous is echo-free. The inflammation is largely in the anterior segment, but in endophthalmitis, the vitreous will have exudates. And then response to steroids is something that can be used to test your hypothesis, whether it is TAS or endophthalmitis. So in this patient, our plan was to manage on lines of endophthalmitis. The patient was admitted in the ward. Intravitreal vancomycin 1 milligram per 0.1 ml and ceftazidime 2.2 milligrams per 0.1 ml were given. Vitreous tap was sent for gram stain, KOH, and culture sensitivity. And treatment instituted was injection ciprofloxacin along with hourly topical moxifloxacin. A steroid loading was given to the eye with betamethasone every 1 minute for the first 5 minutes, followed by 5 minutes for 30 minutes, and then every half hourly thereafter till we get a decrease of inflammation. And atropine was started 3 times a day. This was post-operative day 2. We saw that the hypopion had disappeared. The gram and KOH stain were negative. We can see some breaking of the synapse in the inferior quadrant, and the fibrin had started retracting. We added steroids at this point after ruling out a fungal infection with the KOH being negative at 1 milligram per kg body weight. This was post-operative day 3. The patient could appreciate some hand movements, could count some fingers. We got some fundus view here, a semblance of the disc over here, and the synapse broke further. Intraocular pressure was maintained normal. So the patient had an improving trend. We continued the same treatment. We did not inject further. We did not take up for vitrectomy. We continued since there was an improving trend. We can see the fibrin retracting further, the pupil opening up, and further the media clearing. We can see the disc and that fibrosis that was present preoperatively. This is post-operative day 7. The pupil had almost dilated. There was some fibrin present over the anterior lens surface, and we could see the posterior pole now as we had preoperatively, though still the media clarity was grade 2. There was still some haze. The patient was discharged at that point of time, and this is 2 weeks after the primary surgery. The vision had come back to the preoperative level. The pressures were maintained. And from here, the tapering of the topical and the systemic steroids was started. The fundus had returned to its preoperative level. There was still some fibrin on the anterior lens surface, which might take some more time to go. So it is important for general ophthalmologists that at all follow-up visits, the vision, IOP are checked, the incision site is checked, the anterior chamber cellular reaction, including any hypopion, retract the lower lid to check for the streak hypopion that sometimes you may miss, and the posterior segment media clarity. The posterior segment sometimes mostly may be missed by cataract surgeons. So increased post-cataract inflammation, start frequent topical steroids, and keep the patient with you. Don't send him home. Review him before finishing your clinic. If you feel there is some improvement, okay, send him home, see him the next day. If you feel there is no improvement and the ultrasound shows vitreous echos, always treat on the basis of endophthalmitis, tap and inject, or if you can't do so, take a VR opinion. Thank you.
Thank you, Simar, for a lovely case. Deeksha, can we have your comments?
Yes, ma'am. At the outset, I would like to thank Professor Vishali ma'am, Dr. Chintan, and the executive of COS for giving me this opportunity. And thank you, Simar, for the illustrative case here. So I will be just briefly summarizing the common causes of inflammation following cataract surgery and what all we need to keep in mind. So these are some of the cases some of the causes that I have enumerated, and these can include bacterial endotoxins. Sometimes there can be irrigating solutions which are used, which have a bioincompatible pH, medicines which are used with preservatives, and especially if they are injected intracamerally. And of them, the most notorious ones include benzalkonium chloride or bisulfite stabilizers. So whenever you are injecting anything intracamerally, we should make sure that it is PFBF, that is, it is preservative free and bisulfite free, and especially that applies to epinephrine. And then denatured ophthalmic viscosurgical devices which are left on the instruments if they have not been cleaned after the surgery. And then the use of petroleum-based ophthalmic ointments after doing a clear corneal phacoemulsification.
intraocular antibiotics and at toxic doses, and vancomycin has been notorious for causing such an inflammatory reaction. And as we saw in this case which Simar highlighted, that the recurrence of a coexisting pathology such as uveitis should also be kept in mind. So before taking up any patient for cataract surgery, it is important that we do a meticulous slit lamp examination, including documentation of any anterior chamber cells and flare. So you should be sure before taking up any patient for cataract surgery that there is no coexisting uveitis. The uveitis has been quiescent for at least 3 months, if not more. And sometimes you may need to start perioperative steroids in such situations. Next slide, please. Then you have to remember that there can be intraocular lens related complications which generally have a delayed manifestation. IOLs which have been implanted in the sulcus, they may have the haptics rubbing on the posterior surface of the iris, causing kind of a recurrent uveitis, glaucoma, hyphema syndromes, and especially if you have implanted a single piece IOL in the sulcus, that has a higher propensity. So you should never implant a single piece intraocular lens in the sulcus. Then sometimes retained lens fragments that have been retained during the cataract surgery, sometimes they are obvious because you have a dropped nuclear matter in the vitreous cavity. You know that there has been a PC rent, vitreous loss, and a complicated cataract surgery. However, there may be situations where it is a small fragment that probably has been you have overlooked it, and there is persistent inflammation following cataract surgery. So sometimes you may need to do a gonioscopy and or a UBM to look for whether or not there have been any retained lens fragments in the angle or behind the iris in the ciliary body region. And then any vitreous incarceration in the wound will predispose to increased inflammation following cataract surgery. Next slide, please. So as some steps that can be taken to prevent this, apart from a meticulous preoperative examination of the anterior segment and posterior segment, includes intraoperative steps such as proper cleaning and flushing of the phaco and IA tips and handpieces and other instruments after surgery, use of disposable cannulas rather than the reusable ones, use of lint-free cloth to keep your instruments, and strictly following manufacturer's instructions for equipment maintenance, including the autoclaves. Next slide, please. So key take-home messages are that although clinical clues are there to point towards an infectious versus a non-infectious process, remember that there can be overlaps in clinical presentation. As Simar has mentioned, that you can have an endophthalmitis presenting within 48 hours, and there can be a non-infectious inflammation that can present later. So whenever in doubt, we should always err on the side of infection. And it is very, very important that we are consistent and diligent in all our post-operative follow-ups. And we should always examine our post-operative patients at least once in 24 hours, 72 hours, and 7 days, if not more. Next slide, please. And then if an outbreak is suspected, all efforts must be made to recall and re-examine the patients operated on the same day, and tracing the origin of the outbreak, while it appears daunting, is essential. So you may have to just stop the OT before you find out what has been the cause of this increase of an outbreak. And then you need to investigate the materials used, instrument cleaning procedures that are used, instrument and machine maintenance records need to be investigated to trace the origin of the outbreak. Next slide, please. So to conclude, that whenever there is a doubt, clinically, we should err on the side of endophthalmitis and manage as such. All comprehensive ophthalmologists should learn to give a basic intravitreal injections, because that is not so difficult, and it may help in kind of stabilizing the patient, preventing worsening by the time he reaches a VR setup. And then you should, whenever in doubt, again, keep your VR friends happy and refer early. Thank you.
Thank you, Diksha. Manisha has a comment. Then I'll take a couple of questions which are from YouTube about TB, and we move on to Dr. Dogra's awaited talk. Manisha, please.
Thank you, Vishali ma'am.
Talk.
I just wanted to add a few points to what has been already highlighted by Deeksha. One is that when you are dealing with a patient with a post-op inflammation, it's always a good idea, if you are not the primary operating surgeon, to get in touch with the primary operating surgeon and know what have been the events during the surgery. And is there any, that you're already expecting that there is going to be an undue inflammation, like you've had a PC rent, an anterior vitrectomy has been done, or too much of iris manipulation has been done. So you are already expecting that there is going to be an undue inflammation. So it's always a good idea to refer to the surgical notes or talk to the primary surgeon. The second thing is, it's always a good idea, again, to collect a sample of the aqueous before loading the patient with broad spectrum antibiotics, because that is the most important sample which can actually guide your treatment in future. So often we get patients who are already loaded with all kinds of antibiotics and steroids, and that really hampers the actual signs and symptoms of an endophthalmitis. So please do try and collect an AC tap sample, send it to the microbiome lab, so that even if you've started your basic treatment, you can modify it according to the reports that you get in. And last point I want to raise is, always do a dilated fundus examination. This is a misconception that do an ultrasound and wait for the echoes to appear in the vitreous cavity. They appear much later on an ultrasound. You can actually pick up the exudates much earlier if you have done a good dilated fundus examination. So I think these are a few things which I wanted to highlight. Thank you, ma'am.
Thank you, Manisha. There is a question for me from Dr. Deepak Bhojwani on YouTube, that if a diagnosed case of TB choroiditis throws up a recurrence, is it necessary to perform fluorescein and ICG? Now, Deepak, there are two scenarios. One scenario is you have already treated it for TB and the patient has recurred after, say, 2 years, 1 year, or whatever. Now, if that is the situation, the first thing should be probably it's not TB. Probably whatever you have done was wrong. So you should treat that patient as a totally new patient and do however workup you would do for a new patient, including all the etiologies. The second situation is that, like the patient that was shown today by Dr. Kanika, the TB test was positive, but since the patient was responding to steroids, we decided not to give TB treatment and the patient recurred. So such patients, I always put a note on the file that, okay, for whatever reasons, we are not giving anti-TB, but the test is positive. So if there is a recurrence, you can start straight away on anti-TB drugs without doing a complete investigation profile. The second question which has come up again for me is, there are two questions actually, both from Dr. Akshay Agnihotri. One is, what are the ocular TB signs which warrant the use of systemic TB treatment? Akshay, if you can contact me, I can send you our publications, but I will just summarize what are the signs. Granulomatous anterior uveitis, especially when it is recurrent, not in the first episode. Panuveitis, which has all the components of inflammation. Serpiginous-like choroiditis, tuberculomas, and occlusive vasculitis. These are some of the points when you see these clinical phenotypes, you want to give anti-TB drugs if your investigations are positive. You never treat them based on the clinical suspicion alone. You have to have some positive. And we have come up with elaborate studies both in ophthalmology, which I can forward you for your reference. And another question again from Dr. Agnihotri is there any role of subtenon steroids in tubercular uveitis? You know, I will not give anything which I cannot remove. Like subtenon steroid is something, it goes in the depot. and tomorrow you realize it was TB or it was probably virus or something. So I will not do that. If you are not too sure, it's always good to give oral because that is something you can always stop and taper off if the things are not moving the way you want them to move. We have tried giving Ozurdex in these patients under very close supervision, and once we are sure there is no component of infection and it's purely an immune mediated response. But even with Ozurdex, at the back of my mind, I have this security that worse come worse, I can go in and remove. Subtenon is something which is very difficult to remove, so I will not recommend. I hope it answers, and we go on to last talk by Dr. Dogra, patients as your partners. Please, sir.
Well, friends, we come to this talk, which in fact is a little bit totally different. And I myself was not that much prepared, but anyway, so people wanted me to do this, and especially from the company side. So I thought I'll put few things here, as well as whatever the patients as partner is concerned. What Yes. I think we're going to talk mainly about the diabetic mellitus and diabetic macular edema. It's not that it's a talk which is related to the management and all that. It's the various issues which come up. We know diabetic mellitus has shown increasing prevalence worldwide with high morbidity, and this is a silent disease. Many people, they don't know about it till they come with complications, and that's how they are and sort of picked up. And the problem is, since it is a disease which is lifelong, chronic, so the cost is a big problem here. I think if we look at these figures here, I mean, in 1980, 108 million to 422 million in 2014. So you can imagine where we are going. And so 422 million in 2014, likely to be 642 million by 2040. And more than 60% of the world's diabetic population will be in Asia. And among developing economies, the highest increase in people with diabetes will be in China, followed by India. So I think there are some studies which has been done regarding diabetes prevalence. One was by ICMR in 2011. Here you can see the prevalence of diabetes is from 10.4 to 13.6%. And pre-diabetic population is also 8 to 14.6%. Many of them, they are going to convert. So in 2013, 65 million in India compared to 50 million in 2010. And they have already gone to 73 million in 2017. I think once we look at the diabetes prevalence, the way it has been mentioned here, I think we are leading here in Chandigarh, 13.6%. And although in South also it's more, and in the middle part of the country, it seems it's a little less. Maybe it is also related, like here, to more maybe affluence of people. And diabetes care may be very expensive for patients in low and middle income group countries, since many individuals worldwide lack health insurance. So out of the pocket payment for diabetes treatment may pose large financial burden on these households. So I think that very nicely this in the study which I mentioned here in BMJ Global Health, which is just published recently in 2018. The problem with diabetes is that it involves multi-system. It's not only we are concerned with retinopathy, but there are problems with the cerebrovascular disease, coronary heart disease, nephropathy, neuropathy, peripheral vascular disease in the lower limb, which leads to like ulceration and even amputation of the diabetic foot. So once we come to the diabetic retinopathy prevalence in India, the prevalence of diabetic retinopathy in India is anywhere between 10.6 to 26.2%. Although this is in general, but prevalence, once we look at some of these studies which has been done more recently, one is it's anywhere in the central India, as I said, it is not, but north is very high, 34%. The prevalence of diabetic retinopathy is 18% in urban and 10.4% in rural area. This was the Sun Dream, the big studies done by Shankar Netralia. And so we understand that it is much more with the urbanization or wherever the more affluence is there. And this speed study, we were also part of this. This is spectrum of eye disease in diabetes. So 98% we all know it's a type 2 diabetes, and diabetic retinopathy is present in about 30%. So these are the patients, those who are visiting these 13 hospitals of diabetes. And the hypertension is the commonest association in half of them, 48%. And from ocular point of view, the lens opacities is the commonest ocular disorder, again in half of them. And what is very striking here is that 11 to 12% eyes were blind at the time. That means one eye, whatever, less than 360 at the time of presentation, which is really alarming. So diabetes have a high comorbid burden. This is regarding the diabetic macular edema, especially in the pseudophakic eyes. With the diabetic control, again, these are the, again, diabetic eyes, but not having diabetic macular. You can see the renal disease, the lower limb amputation, everything in this, you can see these red columns is so high once there is a diabetic macular edema. There are so many comorbid, I mean, it's really striking. And this has been published by Kiss et al. In Clinical Ophthalmology. You can go through the details. A majority of the people with diabetes have at least one comorbid disease, and up to 40% have at least 3, increasing the number of visits required to the various. So that's how here it is mentioned, particularly this study by Shiv Prasad et al. In Clinical Ophthalmology, retina specialists, diabetologists, nephrologists, you can see how many visits. These are, so how to reduce the burden, how to reduce the frequency or the burden of visit, that's where the major question comes. So the patient adherence itself is affected by the factors including the age, psychological status. Already they are very, very upset because of the multi-system involvement, expectation of treatment. The treatment mostly for all these things is quite expensive. One has to travel. These specialized treatments are not available everywhere. And the cost, particularly where the patient bear a large portion of the cost treatment themselves. And that is with majority in our population. So we have a lot of difficulties on that. So what is really required is sustained efficacy. So anti-VEGF injections are the mainstay of treatment for diabetic macular edema, which requires, all of us, we know, frequent visits for the administration to maintain visual acuity gain, placing a considerable burden on the patient, the caregivers itself, as well as the whole entire healthcare system. So achieving sustained efficacy with a fewer injection and less frequent visits has been a major focus of research at this time. With new therapeutic options, a lot of these brolucizumab or faricimab or so many others are coming up, and port delivery systems, and which is being developed for especially for ranibizumab, treat and extend regimen, which is being focused more and more because you want to reduce the visits as the number of injections, and sustained release corticosteroids like Ozurdex and Iluvien for various retinal diseases, because these are the ones which are not leading to frequent visits, as well as they last much longer. Of course, Illuvian hardly is available to us and will not be, because it's supposed to be very, very expensive, but Ozurdex is available, which we can use. So mean number of injection in real world, I think I'll not go into detail of this. This you can look at that this is correlated with the improvement in visual acuity. So these are the letter gains with approximately, if you are looking at the number of injections, so here less than 50 letter with 3 injections. And if you want a better, they will keep on, as number of injection improve, the visual acuity improve further. That is what. And so is about the naive and non-naive patient. I think this slide I projected earlier also, and you have to look at this, the burden. So first year, 8 to 10 injection, I talked earlier. Next year, you need something like 3 to 4. And third year also, you will need 2 to 3 injections. So the burden is huge. So what is the real world practice in DME? Vision gains were limited in DME as fewer injections of VEGF inhibitors given in the first year. So this is a study which is published, in fact, recently in Clinical and Experimental Ophthalmology. And you can see the median injection received were 4, although DRCR net mentioned 8. So the real world is, so there are other studies from the real world practice which report similar results and proposed a major reason for inferior visual acuity outcome because of undertreatment. So the poor compliance in patients with DME in real world practice may be due to their work-related obligations, other comorbidities where they have other issues which come up with the body, as well as the major is they have to support themselves. That means the economics plays a major role. So what about corticosteroid? There are 3 options. Either you have, I mentioned about Ozurdex, Illuvian, or a triamcinolone acetonide. So this is usually indicated first in an unresponsive to anti-VEGF therapy, but it can be given as a primary therapy in pseudophakic eyes, or the eyes which has a low risk for glaucoma, or have significant cardiovascular risk. I think they can be primarily started on this treatment. And out of this, Ozurdex is the only one which is already sort of even approved, as well as this is something which is available. And Illuvian is available not in our country, very few countries. And triamcinolone acetonide is a problem. But for a very poor patient, sometimes we may have to use 1 to 2 milligrams if we have no other choice. So the main number of injection in real world studies, this is about the dexamethasone implant. So you can see here again, with the visual improvement gain, the number of injections, mean injections are much less for the similar amount of visual acuity improvement. You can see 1.75 or 1.8 at the upper limit. And in the naive and non-naive patients, again, you can see the visual acuity gain as well as the mean number of injections which are given in the real world situation are much less. So I think there is an advantage, but then we have to understand that lesser number of injections are there, but we have to also monitor them for rise of intraocular pressure as well as for cataract. So the fewer injections, you can see here, this is a study which is published in 2014, and this study clearly mentioned the mean number of injection, you go to the last one here, is 8.6 here for bevacizumab and 2.7 for Ozurdex. With, you can see the burden has really come down here. So this is one way of reducing the burden. So treatment of DME with intravitreal injection therapy required multiple hospital visits. And I think I'll not even go to that what are the real issues are. They have to go to the hospital, they have to travel to the hospital, they have to wait in the hospital, they may have to take a day off from their work, which is very frequent, as well as they also need a person, carrier, most of them with them. And sometimes they don't have, if they don't have a family support, which again is a problem to arrange, and it might be a lot of a issue involved with that part also. So multiple visitation in current epidemic is a problem. But during the current epidemic, multiple visitation is risky. We know everybody is scared. We are scared, and patients are much more scared. Besides being exposed to risk of pandemic exposure, the other disadvantage of multiple have been studied earlier by Shiv Prasad et al. Majority of the patient experience anxiety, even when they are not in pandemic, otherwise also, before they have to go for injection. So, and there are a lot of things here which are mentioned in this study. It's a very good study done, that they were very, they could not relax, they could not sleep. And you can see here that 26% of the patient reported that their sleep was affected a day before they had to go for injection. So multiple visitation in current pandemic, I think you should go through this study, which is in clinical ophthalmology. Then everything is given here, that the whole list, and you can imagine what all that I was afraid. It was difficult to think anything except injection, and all the things which happened there. And also you can see here, again in this particular study, I think a lot of things have been studied. I've already talked about some of these things. So there are so many things which are related, and we have to understand all these things, and we never sort of look at that. So, and the cost, I think this side here was the survey done by our VRSI in 2017. And this is the cost from that. And this has been added here by the company, Elargan itself. So, and you can see here, obviously the eccentrics comes to like almost 23,000, 8,000 here for Avastin, and for eccentric almost goes 50 plus, and Razumab maybe around with the procedure. I mean, it is done. And this, it is longer lasting, as well as it would cost maybe around about maybe close to 30,000 or even less. So in summary, amidst this pandemic, consideration towards patient and treating doctors for social distancing and therapeutic distancing, that is what we are talking, in fact, here. We have to do this therapeutic, and quality of life is important. So for chronic pathology like DME, consideration and planning for the entire year, we can achieve this by either we have something like treat and extend regimen for anti-VEGF, or what we have to do much more at this time, maybe we have to use something like intravitreal steroid like Ozurdex, which might buy more time, less number of visits, as well as it will also decrease the frequency of injection. And I think economics of DME management has to be kept in mind in our country. Individual pays in India for treatment. Insurance coverage and government support is limited. Treatment varies according to the cost outward, affordability, and diverse Indian scenario. And standard of care with some riders need to be followed despite these problems. And we must understand, this is very important, I have mentioned it earlier, often the DME patient would be under-treated and under-monitored because of the various factors, comorbid condition, because of the economy involved, as well as the other factors which comes into play, where frequent visits, loss of work, these are all during the period when they are active. So in conclusion, rise of diabetes is faster in low and middle income group countries. I have shown you some of the data. And in 20 to 30 years, 30 to 50% develop sight-threatening diabetic retinopathy. Those numbers are going to be huge. We're going to be treating, all of us, large number of such cases. And economic impact of diabetes and diabetic retinopathy is enormous, leading to suboptimal treatment. So many comorbidities, so many systems are involved. That's how they can't afford everything. And close collaboration of various partners, especially patient as a partner, is urgently required. I think we need to look at these other aspects which hardly talk, which in fact came up because of this pandemic, that so many things are involved. It's not only just giving an injection or just doing the OCT. So I think we need a much more closer collaboration, and somehow all this would help in future. So thank you very much.
Thank you, sir. Thank you very much. And with this, I would like to thank all of you. I just realized I have one teacher, all students, and Manisha. Everybody is kind of a family in this group. And thank you, speakers. And over to Dr. Chandan.
Thank you, ma'am, and thank you to all the speakers. I think it was a wonderful webinar, really interactive. And I just wondered if we could have all of them, us on video for a moment, just to click a snapshot. And thank you to all the participants also. I believe it's very well attended, although they let me know the exact numbers. I'd also like to thank all Alargan who've really helped with this webinar. And lastly, Mr. Sai from Numerotech, who's been able to provide us with a really seamless experience for this webinar. So thank you all.